guidelines on diabetes in pregnancy. We will be talking about achieving euglycemia in pregnancy with diabetes. And we will be delving into the Indian experience. Please.
Thank you very much, respected chairperson, for this introduction. And my today's talk is on insulin therapy in diabetic pregnancy, and I'm going to just share with you some of the Indian experiences, some of the data we have on pregnancy, diabetes and insulin. But before I start, let me take this opportunity to thank Dr. Sanjay Agarwal, Dr. Arvind, Dr. Vijay Neglur sir, Neeta and Dr. Anjali Bhatt, and of course all people from Pune for wonderful organization of this meeting, which I am enjoying since morning, almost 8 o'clock, and I was told by Dr. Neglur that we are going to be here till 8:30 in the evening. So it's 12 hours marathon, academic marathon, which we are going to face. Hopefully I will not bore you, rather we'll try to give you some of the clinical tips in this exhaustion of since morning on insulin therapy. And unfortunately we don't have very good data available of the use of insulin therapy in pregnancy diabetes. Most of the data is coming from Western world. Indian data we hardly have anything except some data from Professor Shia and Balaji group. But before that, to just introduce what is euglycemia in pregnancy, you should, whenever you diagnose gestational diabetes or whenever you diagnose pre-gestational diabetes, you have supposed to achieve a target fasting of less than 90 or 95. 2-hour value should be less than 120. Some of them they are following 1-hour value, which should be targeted to be achieved as less than 140, and mean blood glucose should be less than 105. We should see to it at 3 o'clock in the night, it should be above 70, that should be a target. Now to achieve this target, you have first is medical nutrition therapy. According to the Western literature, around 70 to 80% of them, they can achieve this goal of 790 and 120 blood glucose with medical nutrition therapy, as well as exercise. But few of them, they may need insulin therapy. Oral drugs is not the topic of discussion today. There is some controversy, and unfortunately, up till now, we don't have the recommendation from Indian authorities to use oral drugs in pregnancy. Though we have recommendation from ADA, though we have recommendation from ACOG, though we have recommendation from FIGO to use metformin as well as levetiracetam for gestational diabetes, but not for pre-gestational diabetes. So we remain at this moment of time the use of insulin for achieving this euglycemia. These are the national guidelines for diagnosis and management of gestational diabetes, and it says that if you diagnose some person as GDM, hyperglycemia appearing typically during pregnancy, wait for 1 to 2 weeks to achieve 90 and 120 goal on diet therapy, lifestyle modification, exercise. If you fail to achieve this goal, you should switch, you should start using insulin therapy. Insulin therapy, as I told you, around 20% of them they may require insulin, but our own data on GDM, which is yet to be published, around 930 or 40 patients. And in these individuals, we have found that around 50% of our Indian GDM women may require insulin. Another 50% may do well with diet therapy alone. Insulin requirement may be little higher in obese versus non-obese, may need to increase progressively as the pregnancy advances to term, and self-monitoring of blood glucose actually guides you the time and the doses of insulin therapy in a given woman. What is important is, if you diagnose hyperglycemia in the first trimester, second trimester it will further increase, and till delivery it will go on increasing. So that also we have to understand. Which insulin is safe in diabetic pregnancy? Regular insulin, NPH insulin is category B. Retimilin is again been approved. Nispro and Aspart has been approved. Glulysin, Glargine, Tegludec, these are the insulin which are not approved to be used in pregnancy. Though we have some data again coming up in favor of Glargine to be used, but still the authorities say that the given opportunity, withdraw Glargine and switch over to Levemir insulin. If there is no absolute indication for Glargine insulin, then we should be switching over to Levemir insulin at this moment of time. Insulin regimen in pregnancy diabetes. As we know, our dietary pattern changes from normal days to weekdays, and sometimes you have various kind of hyperglycemia, especially in the postprandial state. If it is pure gestational diabetes, patient may come to you with postprandial hyperglycemia. Fasting might remain normal, and if the postprandial hyperglycemia exists, you have to use regular insulin or short-acting, rapid-acting analog insulin with breakfast, lunch, and dinner, depending on their postprandial hyperglycemic status. But if it is a pre-gestational diabetes, you might need to achieve fasting blood glucose control of less than 90, for which you need to give long-acting insulin or maybe NPH or levodopa insulin. And I think we are all aware of that analogs are better, have better physiological action, and they control postprandial better versus the regular insulin, and we should be preferring that. Now you might have, there is some data which says that twice a day insulin also suffice and can achieve your fasting postprandial blood glucose well, but using mixed variety of insulin or pre-mixed insulin in patient with GDM might be little difficult for a person like me, where I know that fasting is only 70s and 80s, and pre-mixed insulin may cause little hypoglycemia, especially nocturnal hypoglycemia if you use it in night. So in the messages, if it is a pure gestational diabetes, the fasting is already normal, one should use regular insulin or means the short-acting insulin or rapid-acting analog. Now twice a day versus 4 times a day insulin regimen, data says glycemic control is better with the 4 times a day insulin regimen, that is basal bolus regimen, versus the twice a day insulin therapy. And this is very rightly, it has been pointed out that postprandial glucose control is better with aspart versus the regular insulin. There is another new insulin which has just been approved in US, and that is insulin, faster insulin aspart. And this is nothing but the insulin aspart, where they have added niacinamide and L-arginine and for the stability, and that's vitamin B3 and L-arginine. And now they have made this insulin aspart insulin has become more faster acting insulin or faster aspart. It has been named faster aspart. And the data has shown that faster aspart seem to be better versus the regular insulin. So faster aspart controls postprandial better at 30 minutes and 1 hour time versus the faster already available aspart insulin. Compared with faster, twice as fast onset of appearance in the bloodstream, 2-fold higher insulin exposure within 30 minutes, and around 74% greater insulin action within 30 minutes if you use faster aspart, but it is yet to be launched in India. And this is a faster acting insulin meal test blood glucose profile, where you can see the faster has controlled it better versus the controlled it better than the insulin aspart. Now insulin dose, and we should know that in the first trimester, around 6 to 8 or around almost 10 to 14 weeks of pregnancy, that is first trimester, the insulin resistance actually goes down, and you may require a little less dose of insulin if it is a pre-gestational diabetes. After around 20 weeks of pregnancy, insulin resistance goes up, insulin requirement goes up. Up to 34 weeks, you might need to go on increasing the dose of insulin, which ultimately need to be reduced after 24 weeks of pregnancy. This is a natural course in the requirement of insulin therapy in pregnancy. Now, the data has shown that during pregnancy, insulin requirement tend to fall during first trimester, rises during second and third trimester. We need to weekly increase the insulin dose requirement from 24 to 38 weeks. From 31 to 39 weeks, maybe that it is little stable. And insulin requirement is around 0.8 unit per kg body weight for non-obese and 0.9 units for the obese individual. Varies from 0.7 to 2 unit per kg body weight. Total was around 40 to 90 units of insulin. This is data from Coded Langer and Hirsch, and this data is a Western data. Now what we have found from our data. Now this is a paper 2003, almost 14 years from now. Only a small number, 158 pregnancy, and we have found their insulin dose frequency relation between pregnancy weight and BMI. But I just come to the dose here. We have two categories. One is IGGT, which is now being just called as gestational diabetes. In some of the Western literature, they call it as mild GDM. Give 75 gram glucose. If the 2-hour value is more than 140 is GDM. But some of the people have 120 to 140, that is called as mild gestational diabetes. Earlier we used to classify it as IGGT. They also require around 15% of them they require insulin, but less than 10 minutes per day. Here 23 GDM is 23 minutes and 52 minutes. Dose increased from 1.5 times to 2 times from diagnosis to delivery. They are Indian patients 14 years from now. GDM dose was double that of the IGGT, and pre-ADM was double that of GDM. Now the message from this is, if it is a borderline case, mild GDM, which is 120 to 140, require less than 0.2 unit per kg body weight, pre-pregnancy body weight. GDM require around 0.4 unit per kg pre-pregnancy body weight, and here pre-GDM require around 0.8 unit per kg body weight. and the dose was lowest at breakfast. And unfortunately, in our data, it doesn't match with the southern data. South India, they say that breakfast dose is highest, but in our data we have found that the pre-dinner dose is highest, and our population require highest dose at dinner time and lowest at the breakfast time. Pre-dinner dose was almost double that of breakfast. Now, we have another data which is just published almost last year, which is 14 years from now, and this is insulin therapy in women with pre-gestational diabetes. And what we found is the first trimester pre-gestational diabetes, type 2 diabetic women, they require around 0.58 per kg body weight, and then the third trimester around 0.8. So it matches with the dose which we have seen almost 13 years from now. And again, if you see the breakfast versus this is first trimester and third trimester, breakfast versus dinner time. The dinner time dose requirement is higher at diagnosis, whereas at the time of delivery, there is a third trimester, and some of the pre-GDM women require long-acting insulin, which you can see here, which is less than the short-acting insulin. So majority of them, they require basal bolus regimen, where you have short-acting, and a small dose of long-acting to achieve the fasting goal. Message again here is breakfast, lunch, dinner. This is calorie requirement probably in central India where I belong to. We are very heavy, we have light breakfast, we have heavy lunch, and we have heaviest supper. And that it could be one of the reasons that they require higher dose, but unfortunately we never monitor our post-dinner blood glucose. Those who have hypothyroidism, they require higher dose versus those who did not have, as first trimester as well as third trimester. Then there is again those who have PIH, again requiring higher doses versus those who don't have. There is birth weight, and this is again very interesting slide. Those who did not progress from first trimester to third trimester in a statistically significant manner, the insulin dose 31 to 38, as well as macrosomia 49 to 57, but those who progressed well probably monitored blood glucose much better and had delivered normal baby versus those who could not, their increase in the dose was not statistically significant. A very light message to you is try to monitor them and try to go on increasing the dose of insulin as per the requirement. Probably you will have a normal baby, chances of having normal baby is more versus if the increase from first trimester to third trimester is not significant. So mean insulin requirement from first and third trimester deliver different weight that we have seen. Again, hypoglycemia and insulin requirement. Yes, those at the third trimester, neonatal hypoglycemia was more. I'll just skip this. About the twin pregnancy. Now, we have seen pre-gestational diabetes. We have another cohort of twin pregnancy. I'll just take you to this paper of diabetes here. It says that in type 1 diabetes, twin pregnancy will require twice as much insulin as versus the singleton pregnancy. It has opened our eyes because I was not finding this, and I then shared with some of my other colleagues. Did you find this? They said, no, it is not possible. Some of the gynecologists are very group. So we have found our own data. We collaborated around 915 women with hyperglycemia. Out of them, around 24.6% had twin pregnancy, and a few of them were GDM, and few of them were 18 and 6 were pre-GDM. And then we have considered a few of them on insulin. Now, what we have seen, those who were on insulin, there is no significant difference whether you have twin pregnancy or singleton pregnancy in first trimester as well as third trimester, in GDM as well as pre-GDM women. The insulin requirement in twin pregnancy was not statistically higher versus the singleton pregnancy, and that's another message we got in Indian cohort. Increase in the insulin dose at full term compared to baseline again was not very significant. But those who had hypothyroidism, PCO, PI, and those who had wide obstetric history, they have more, the twin pregnancy have more higher risk of having this maternal complication versus singleton pregnancy. And that was in GDM as well as same in pre-GDM. The insulin requirement was higher. So GDM or type 2 pre-GDM women with twin pregnancy don't require higher insulin doses versus singleton pregnancy. GDM with twin pregnancy are at higher risk of having PCO, PIH, and had wide obstetric history. Macrosomia is not common in twin pregnancy. Most of them were underweight. Now the last part is insulin in gestational diabetes. at diagnosis as well as at delivery. This is unpublished data for 915 pregnancy. Those who diagnosed less than 12 weeks, 12 to 24 weeks, and more than 24 weeks at diagnosis. And the insulin requirement again, if you see, at delivery it is going up versus diagnosis. Breakfast, lunch, and dinner. Again, the dinner dose was much more higher versus the breakfast and lunch dose. And then we have the last cohort is gestational diabetes. So we still have 2.5 minutes, 3 minutes plus. Now, about gestational GGI, gestational glucose intolerance, which is called it as mild gestational diabetes. Even amongst these women, the dinner dose was found to be higher at diagnosis, and in delivery again in those who diagnosed at 12 to 23 weeks they require higher dose. What I mean to say here is we are monitoring most of the time post breakfast and post lunch blood glucose, but unfortunately post dinner blood glucose is not being aggressively monitored in our population. We should be monitoring these blood glucose also well, because if you don't monitor it, it will remain untreated, and this single spike of post-dinner hyperglycemia might be a problem for unexpected outcomes. Again, the mean insulin requirement, this is the GGI patient, around 189 patient. 16% of these mild medium women require insulin at breakfast, lunch, and dinner. And if you see, the mean insulin requirement at delivery as well as at diagnosis, with dinner time is higher versus lunch time and breakfast time. Now, there are generally few patients who are requiring very high dose of insulin, and insulin being a drug of choice, and you're not able to achieve the control. Data says you can add metformin to insulin therapy in women with insulin-resistant diabetes with pregnancy seem to be effective and reduce hospital stay, reduce frequency of maternal hypoglycemia, reduce frequency of neonatal hypoglycemia, and ICU admission and neonatal RDS if you add metformin to this. We have also used insulin pump in some of the individuals, and we call them as pump babies. This is a type 1 diabetic patient, 22 years, with 7.9 HbA1c at the time, diagnosed with 7 weeks gestation. Unfortunately, she has proteinuria as well as moderate NPDR, but she badly wanted to go for pregnancy. She continued this pregnancy, and she was on multiple doses of 1, 2, 3, 4, 5, 6 picks of insulin per day. She had brittle diabetes, so she was on insulin pump, 6 basal and 6 setting, and it was Kavita was monitoring it on almost regular basis. She was a pump trainer, and we could deliver no underweight baby because of hypertension, but there was no congenital malformation. Baby and mother was healthy afterwards. We have used the same pump in type 2 diabetic, 30 years, and she was requiring around 185 units of insulin earlier, and then she had PIH, oligohydramnias, but ultimately she was reduced to 124 units of insulin, which was again managed by 3 basal and 5 bolus doses through pump, and normal outcome, and now she is only on metformin. So we can use in some patients, we can use insulin pump in patients who have brittle diabetes, in some rare patients, but the outcome remains almost the same. Finally, insulin is the drug of choice if MNT alone cannot achieve adequate glycemic control. Insulin analogs, Lispro, Aspart, and Etimine have proved to be safe and efficacious. Insulin glargine, though evidence is promising, but still a question mark. Pump, a safe, reliable method for satisfying the basal insulin need, but outcome is same versus multiple daily doses of insulin. Data from Central India needs higher insulin doses at dinner versus breakfast. With this, I stop here, but before I stop here, let me invite you for the next South Asia Initiative for Diabetes and Pregnancy, which is called as SIDEC meeting, which is going to be happening for the first time in India in May 25th to 27th May 2018. Those who are focused people for pregnancy diabetes, they are all invited to have an interaction and attend this. Thank you very much for your patience.